courts. And to begin with, let's talk about dangerous pathology in general and the professional obligations when we encounter a dangerous pathology. There are three dangerous pathologies in clinical psychology: suicide, homicide, and abuse. Child abuse, spousal abuse, and elder abuse. When a mental health professional encounters a dangerous pathology, suicide, homicide, or abuse, a duty to protect is active, and the professional must do three things. First, the mental health professional must conduct a proper risk assessment personally or ensure that a proper risk assessment is conducted to the danger that's involved, either suicide or abuse or homicide risk. The second act that they must take is some sort of protective action, an affirmative protective action. They must do something. Now, for suicide, that might be increasing the frequency of sessions or activating support networks around the person with proper permissions. But the mental health professional has to do something to make sure everyone's safe. For child abuse, it might be the referral into Child Protective Services for an investigation. Then the third thing that the mental health professional must do is document the findings of the risk assessment, if they conducted one, and the protective action that they took. And that should be documented in the patient's medical record, their chart. If the rule of thumb in documentation is if it's not documented in the chart, it never happened. So if you have a suicidal patient, you need to conduct a proper suicide assessment and then document the findings of that in the patient's medical record. There are four types of child abuse in the DSM-5. Child physical abuse, V995.54. Child sexual abuse, V995.53. Child neglect, V995.52, and child psychological abuse, V995.51. Now, V-code diagnoses are modifying diagnoses to the primary DSM-5 diagnosis. So the child abuse diagnosis of a V-code is added to the primary DSM-5 diagnosis to modify it or help explain the source of the problem. So in the family courts with the allied parent, the primary diagnosis would be the delusional thought disorder shared, a persecutory type, 297.1, and a factitious disorder imposed on another, 300.19, and I discuss those in other seminars. Then the child abuse diagnosis, child psychological abuse, would be added to those as a modifying diagnosis because, excuse me, creating a delusional thought disorder in the child that then destroys the child's attachment bond to the other parent, the factitious attachment disorder, is either one of those or both of those would represent child psychological abuse. Now, for the reason to diagnose the full scope of the issues involved is that every diagnosis that is provided needs to be addressed on the treatment plan, and a treatment plan cannot address an issue if it's not diagnosed. So, for example, the first diagnosis, the delusional thought disorder, the treatment plan for that might be something like protective separation from the primary case, which is what's recommended from the American Psychiatric Association. And then we would want to correct the cognitive distortions and stabilize the child's normal range perceptions. So that would be the bullet point on the treatment plan, one of several probably, but dealing with the delusional thought disorder. Then for the factitious disorder, the treatment plan might indicate a protective separation from the inducer, which is again the recommended treatment for a factitious disorder imposed on another. And then restoration of the normal range attachment bond to the targeted parent. And then the intervention might be something like the contingent visitation schedule for that. So that's what would look potentially a bullet point on the FDIA treatment plan. For the child's psychological abuse, it would be protective separation from the abusive parent, which is the treatment for all forms of child abuse. And then we would restore the normal range functioning of the child and monitor the child's abuse, child psychological abuse symptoms, which would be affection with the targeted parent, cooperation with the targeted parent, and social involvement. So that would be what the associated treatment plan features for the various diagnoses would look like. And let me start by noting that in all three of those treatment plans, it's a protective separation. That's the treatment for a shared delusional disorder. The APA, American Psychiatric Association, indicates that twice, that if you separate the child from the primary case of the delusion, the child's symptoms will disappear. And then the treatment for a factitious disorder imposed on another is also a protective separation of the child from the primary case, the inducer of that. And so the protective separation is the treatment for both of those disorders, and it's the treatment for child abuse, all forms of child abuse. So while those are consistent across all three diagnoses, each treatment then would take a variant look at or a variant approach to addressing that specific issue. So, for example, with a delusional thought disorder, we're correcting the cognitive distortions. With the factitious attachment pathology, we're restoring normal range attachment bond. And with the child psychological abuse, we're monitoring the child's symptoms. So while the treatment for each of those diagnoses is in some respects the same, the protective separation, they are each addressing a different aspect of the pathology, and that's why we diagnose everything that's relevant. So for the targeted parent abuse diagnoses of concern, we're worried about physical abuse, sexual abuse, neglect abuse, or psychological abuse. Let me talk about that for a second. We have an attachment pathology. Attachment is a motivational system, so it always motivates the child to bond to the parent, because the other motivational direction is death by starvation and predation. So it's a motivational system. All motivational systems, eating, sex, pain, pleasure, attachment, they all motivate towards a direction. If we have a directional change in the child's attachment motivation, the child is seeking to flee a parent, then that's caused by child abuse, either by the targeted parent, which would be typical in the general world, or by the allied parent, which is common in the family courts, a factitious attachment pathology imposed on the child. So, but the first rule out for a child seeking to flee a parent would be child abuse by the targeted parent. But we don't know what type of child abuse is creating the child's desire to flee. So that would be our first rule out. What is a targeted parent abusing the child in some way? And we have 4 types of child abuse. Now, in terms of assessing child abuse, the concerns or suspicions of physical abuse, sexual abuse, or neglect abuse are mandated reports to Child Protective Services for investigation. And I'll discuss why that's really important in a moment. Psychological child abuse, though, is not part of that mandated reporting requirement. And so for child psychological abuse, though, duty to protect is still active, and it's still abuse, and it's still a dangerous pathology. So the mental health professional who's involved still is required to conduct a proper risk assessment for the danger for the child's psychological abuse by the one parent or the other, depending upon the situation and symptoms and allegations. Now, I've worked in foster care, okay, and I was a clinical director for 3 university assessment and treatment center for children ages 0 to 5 in foster care. Child Protective Services was our primary referral source. So I've personally treated all 4 forms of child abuse, and I have led the treatment teams that have included CPS involvement for all those forms of child abuse. And in working with CPS and how the mental health professionals should respond to the findings of CPS is that a true allegation or unsubstantiated false finding from CPS are accepted as definitive. No additional assessment should be undertaken by the involved mental health professional. So let me emphasize that. Child Protective Services, they are trained to conduct a proper risk assessment for the physical, sexual, and neglect abuse. Allow them to conduct the assessment. If you're going in and as a mental health person and conducting some sort of assessment, your questioning can be wrong and you'll corrupt the forensic evidence. So when we have possible child abuse, there's 2 things we want to do. First, protect the child and protect the forensic evidence so that we can get a prosecution off of the child abuse. So allow CPS at a very low threshold, a suspicion of possible child abuse. Get it over to CPS for Child Protective Services for a proper risk assessment. And when that comes back as either substantiated, true, or unsubstantiated, false, we accept that. They've conducted the assessment. We don't go back in and try to reassess the situation because we're just going to wind up influencing the child and messing things up potentially. So those 2, true or false, are accepted by the mental health professionals as accurate. Now, for an inconclusive or an uncertain finding from CPS, that remains an open clinical concern. It continues to remain a rule-out diagnosis. And additional information arising in further treatment should receive an additional CPS report for further investigation. So now in making these decisions about whether or not it's child abuse, the danger is we're going to make a wrong decision. And that has to do with decisional error. And it's type 1 and type 2 errors is how it's formally described. And it can be kind of confusing when you encounter this in graduate school. But when we make a decision, there's 4 possible outcomes. It can either be a true allegation or a false allegation. And our findings will either be that it's a true allegation or a false allegation, which creates 4 types of decision. 2 of those are accurate. So there's a true allegation and a true finding is a true positive, and a false allegation and a false finding is a true negative, okay, that nothing was there. But it also has 2 decisional errors. One is when it's a false allegation of abuse, but our finding is that it's a true allegation. That would be considered a false positive. And then the reverse of that is when it's a true allegation and our finding is that there was no child abuse. That's a false negative. Now, the concern with child abuse, the one that we are looking at, the box, is the true positive. That's the one we're concerned about. There's a true allegation and our finding comes back true. We need to protect the child. The errors are the false positive and the false negative diagnoses, and those are the ones we would want to avoid. Now, as one of the features about these, just making a decision about this, is that the more likely we are to identify the true positives, then we are also more likely to identify false positives And then also less of the true negatives will also be identified. Those will be decisional errors. So the more true positives we get, we'll make more errors. And conversely, as more true negatives are identified for any decision about anything, the more false negatives and less true positives will also be identified. So we'll make more decisional errors. So where we set our criteria for the making a decision is going to influence how many true and false positives and how many errors of various sorts we make. So the question becomes, as setting our criteria for deciding, yes, this occurred, preponderance of evidence or beyond reasonable doubt sort of things in clinical psychology, is which decisional error is worse? What's the outcome? Which is the worst outcome? And this is a values judgment. There's no criteria for this. It's just deciding which of those false errors is more damaging. And with child abuse, the false negatives are worse. A false positive creates damage to the parent. That's a false allegation that we believe is true. And so that's going to harm our error in that decision is going to harm the parent. If we make a false decision the other way, that's going to harm the child, the false negative. Let me say something about that because this is really important. For a child to allege child abuse by a parent is a very hard thing for the child to do for a variety of reasons. Children do not typically want to allege child abuse by a parent for a variety of reasons. For physical abuse, that's a dangerous parent. For sexual abuse, it's going to destroy the family, and there's all sorts of loyalty things involved. And so it's very hard for the child to make that allegation. So when the child is able to overcome that reluctance and make an allegation of child abuse towards an abusive parent, for that child not to be believed, if we go, I don't believe you, and we send the child back to be with that abusive parent, that is devastating to the child. And the child will never report abuse again because they weren't protected. If we send them back to a physically abusive parent, that's dangerous. If we send them back to a sexually abusive parent, that's dangerous. The child reported and nobody protected them. So that is a devastating response. And so I'm very reluctant to disbelieve a child who's alleging child abuse. So for child abuse diagnoses, we want to limit the false negative misdiagnosis that the child abuse is present, but we say it's not, we say it's absent. And we want to increase the true positive diagnoses. When the child abuse is present, we want to accurately identify it and protect the child. Now, for me, I want a true positive of 100% and a false negative of 0%. But that means I'm going to get higher rates of false positive and lower rates of true negative. So here's my value system. Coming from experience working with children who are authentically abused, is for the children ages 9 or older who make a specific allegation of abuse. I will believe the child's allegation 100% of the time, because not believing a true allegation is so devastating to the child. I want 0 false negatives. Now, children ages 0 or ages 9 and above, they understand what they're alleging. They have enough cognitive ability to understand what the meaning of child abuse is and what's going to be involved with the parent. So if a child is knowingly making a false allegations of abuse towards a parent, there's substantial problems in that family, more problems than simply the allegation, false allegations. That's a problematic family. And I've worked with a few of those. And now my criteria, though, will increase the frequency of false positives, identifying the child abuse is present when it's not present. But I will not sacrifice a true allegation child to disbelief to save a false allegation child who's knowingly making a false allegation because they are in a very problematic, dysfunctional family. Now, for children ages 6 and younger, um, who make a vague allegation of child abuse, I'm more comfortable with questioning the allegation with clinical judgment. Now, for children ages 3 to 6 years old, the reason for that is because the difference between truth and pretending are more variable and fluid for them. Their cognitive development is immature, and they're susceptible to influence. That's the Santa Claus delusion. We can get children to believe that reindeer are landing on the roof and their Santa Claus goes to every house up until about the age of 6 and then 7 and 8. So you can see what, if you just use your Santa Claus delusion as a guideline, somewhere between 7 and 8, the child begins to pick up that this is not true. So for younger children, it's what we want to look to is the specificity of reporting and the context features that suggest influence, such as prior interviews by a motivated parent. Those are all considerations. Now, let me say again, though, this should be conducted by Child Protective Services. Now, because I have worked directly in child abuse world and worked with CPS, I know what they are, and they would send their kids to me, and so these would be the decisional criteria. However, even though I am capable of assessing physical, sexual, and neglect abuse, and I was running a clinic, and these kids are coming in, if we had an abuse allegation emerge as part of our treatment, for example, the child was taken away from a meth-addicted mother, and that's child neglect, and put in foster care, and then was sent to our clinic for treatment. If our therapist began to suspect there was possible sex abuse with the child because of the child's play or something, we would not probe that. We would not go further into evaluating the possible sex abuse. We would continue to treat the child around other things, but we would immediately make a referral into Child Protective Services again. And they would conduct the sex abuse investigation and send them back. And as soon as we got the substantiated or unsubstantiated, we would then direct our therapy to that finding. So even with all my experience, I will not assess physical, sexual, or neglect abuse. Psychological abuse, though, is, because it's more complicated and complex, and CPS is not currently trained to assess for that. So in child abuse reporting, the child's first report is the most critical information, and CPS, Child Protective Services, should be the first interview, not the mental health professional, not the parent. So mental health and parents should not interview children about physical, sexual, or neglect allegations or concerns. A proper CPS interview is needed. Substantiated and unsubstantiated findings are accepted as definitive. If it's substantiated, the CPS findings are true allegations. The abuse occurred. If they come back substantiated, the abuse occurred. Unsubstantiated, the CPS findings are false allegations and no abuse occurred. That's definitive. If they come back inconclusive, uncertain, then the CPS findings remain open clinical concerns and remain a rule-out diagnosis for the treatment providers. So let's talk about psychological child abuse now. So mental health professionals and parents, as I said, should not interview children about physical, sexual, or neglect abuse allegations or concerns. A proper CPS investigation is needed, and substantiated and unsubstantiated are definitive. Now, for psychological abuse is not a mandated report to Child Protective Services, and the investigation of psychological child abuse is simply too complex and sophisticated for the current level of CPS training. So, but duty to protect obligations are still active. It's still abuse. So the assessment for psychological abuse should be conducted by a qualified, a competent mental health professional. Now, CPS, Child Protective Services, is not currently set up to assess for child abuse, child psychological abuse. However, that's because of a broken mental health system. Once we fix the mental health system around the family courts, then there is a role for Child Protective Services in the assessment, and I'll explain that here, is that once we fix the mental health system, once the court-involved psychologists begin properly assessing and diagnosing the child's psychological abuse in the family, this will then allow for a solution that includes CPS investigation. And what would happen is that when a court-involved psychologist makes a report to CPS of a child psychological diagnosis, child psychological abuse diagnosis. So the court-involved psychologist makes the diagnosis of child psychological abuse. They then report that to Child Protective Services, and a specially trained CPS social worker who understands court-involved pathology can then assess for the features of concern to confirm the diagnosis made by the court-involved psychologist. The appellate system for disputed diagnosis is second opinion. So if the psychologist makes a diagnosis of child psychological abuse, refers it into CPS, CPS can go and look for the same features of the persecutory delusion, factitious disorder, and things, and a well-trained or sufficiently trained CPS social worker can then confirm the diagnosis made by the specialist psychologist in the family courts, and then the court would get two confirmed opinions that this is child psychological abuse, one from a specialist psychologist who works in the family courts, and the second from a specialist CPS social worker who's familiar with child psychological abuse. So once we fix the mental health system and get the psychologists doing what the psychologists are supposed to do, then we can also fix the legal system. We can fix the CPS response to child abuse. So important to understand is that all mental health professionals have duty to protect obligations. And when child psychological abuse is a considered diagnosis, a professional duty to protect is active, and a proper risk assessment for psychological child abuse needs to be conducted by the involved mental health professional, the family therapist, the child's individual therapist, the forensic evaluator. I don't care what role you're in, you have a license. You are a mental health professional. And if a dangerous pathology, suicide, homicide, or abuse is of concern, your obligations are to either conduct a proper risk assessment personally or ensure that one gets conducted. For psychological abuse, it's not a mandated report to CPS, so your obligation is to personally conduct the risk assessment, and if you're not qualified to do that, then ensure that it gets conducted by somebody who is qualified. So inform the court that it needs to be conducted, and let's get a proper assessment from the professional psychology. So what is the definition of child psychological abuse? It's a vague term. So from my definition, it's creating significant pathology in the child. So creating significant psychiatric pathology, a delusional thought disorder, DSM-5 297.1, and a factitious disorder imposed on the child, DSM-5 300.19, those are both child abuse, either one and both. Creating a delusional thought disorder that destroys the child's attachment bond with the other parent. Now, other than that, I would suggest that potentially related to the targeted parent, if there's allegations of psychological abuse of the child by the targeted parent, that might be a parent who's excessively angry, excessively hostile, critical of the child, or excessively shaming. And so those type of features may represent child psychological abuse. However, we also have to consider cultural values, personal values, and religious values when we're considering child psychological abuse under those sort of more broad or vague descriptions, because we want to be careful that we don't bring our value system from like a white Northern European parenting and then pathologize parents' value systems that might be different. Religious value systems can be more strict, and some cultural value systems can rely more on shame as a social regulator and things. And if we identify problems that we are concerned about, those go on a treatment plan. Whether or not it's abuse and reaches that level is a more cautious consideration. However, if we have a delusional thought disorder and a factitious disorder, those are clearly child abuse, which is why I anchor in that first definition. I anchor everything in the DSM-5. We need to get a DSM-5 diagnosis off of this situation. Now, normal range parenting, to talk about parenting generally. In the absence of child abuse, parents have the right to parent according to their cultural values, their personal values, and their religious values. And in terms of the court-involved custody issues, in the absence of child abuse, each parent should have as much time and involvement with the child as possible. That's the only opinion that comes out of clinical psychology. The court can look at all the evidence and decide one parent gets, school week primacy and the other one gets every other weekend. That's not a decision for the doctors. That's a decision for the court. And in the absence of child abuse, to restrict either parent's time and involvement with the child would damage the child's attachment bond to that parent, thereby harming the child and harming the parent. Doctors do no harm. And so in terms of child abuse, if there's no child abuse, parents have the right to parent according to cultural values, personal values, and religious values. So here's the differential diagnoses we're concerned about in the family courts. With the targeted parent, we're concerned about physical abuse, sexual abuse, neglect abuse, or psychological abuse, creating the child seeking to flee the parent. What's happening? If there's no abuse by the targeted parent, then the rule out, the differential diagnosis on that is that the allied parent is producing the pathology. They're creating a shared persecutory delusion. They're creating a factitious attachment pathology in the child, which is child psychological abuse, and spouse or partner abuse psychological. So we got two dangerous pathologies. The other one is spousal abuse, using the child and the child's induced symptoms as a weapon. Both of those need assessment because they are both dangerous pathologies and both need to be accurately diagnosed and addressed when they're present. So in terms of an assessment for the child abuse in the family courts, or the concerns for that, I recommend about 6 sessions. We can expand it or limit it depending. But this would be my standard protocol, 6 sessions. So the first 3 sessions, I would meet first session with the allied parent because I want to obtain history and symptom information. And I want to get the worst allegations of abuse because it could be possible abuse by the targeted parent. So tell me what the abuse is that's going on that makes this child want to flee that parent. And so I'm going to get reporting from the parent first, not from the child first. Because when I go into my child assessment or interview, I want to be informed. I don't want to be walking in blind. I want to conduct a skilled assessment. And so I want to get the information first, and the allied parent will give me that information. It will also allow me to conduct a mental status exam of thought and perception with the allied parent. And I discussed that in the discussion of assessing and diagnosing a delusional thought disorder. Now, the second session I'm going to have with the targeted parent. And that's, again, to obtain history and symptom information from their perspective, but also to assess their response of the targeted parent to the allegations. This is where I'm going, if I get substantial allegations from the allied parent that are concerning, I'm going to then present those to the targeted parent and see their response and hear their response. and I'm assessing whether or not they are the abusive parent. That would be a narcissistic parent, and I can see what their response is to the allegations. Then the third interview I'm going to conduct with the eldest child, because typically that's the targeted child that the allied parent will seek to form the alliance with. But I'll look at the age ranges of the children for this, and let me talk about that for a second. So if we have multiple children in the family, I will definitely want to talk to the most affected child, the eldest child. But if we have secondary siblings, we have a 14-year-old older child and a 12-year-old and a 9-year-old, I'm going to want to meet with the 12 and the 9-year-old, but I might meet with them separately because I don't want them influenced by what this child is saying, because they might have varying degrees of disrupted attachment with the parents. So I might interview them separately. If I have a 4 or 5-year-old, I may not even interview them if they're part of a sibling set, depending upon the circumstances. If I have adult children, I might wind up interviewing adult children, who grew up in the family or have relevant information. So that's sort of on a case-by-case basis. But I will want to speak with the primary child or children. If we got a couple children, 15-year-old and a 14-year-old who are very much in the same mindset based on the previous reporting I've received, then I might interview them together. So it's a variable thing. What I want to do from that assessment, though, is to acquire the child's reporting about what's happening. Why are you seeking to flee that targeted parent? What are the reasons for that? Doing a little bit of a mental status exam with them as well. What's the reasoning? Is there a there there? And then I'm going to take what their concerns are, and I'm going to bring them into the parent-child session and see what the situation with the symptoms actually look like. So that would be session 4, is when I bring the targeted parent and the child together and to directly observe the child's symptoms. Are they, extremely anxious and huddled in the corner and stuff, or are they engaged? Are they hostile with the parent? And so I'm going to do an applied behavioral analysis of the conflict incidents that were reported in sessions 1 and 4, and using probes of response to intervention here. So I have another seminar on assessing parenting, and talks about applied behavioral analysis and behavior chain interviewing. And so I'm going to acquire some of these incidents, the unforgivable event type situations, from the allied parent in session 1, from the child in session 3, and then in session 4, I'm going to do an applied behavioral analysis with the parent and child, the target parent and child, walking through those incidents step by step to see the cue structures, to see the reinforcers and things that were involved there, and see the discrepancy in just perception of the situation. And then in that session as well, I can also probe on response to interventions. So I say, let's say we were able to fix all the problems with this parent here. Would you then be willing to bond to this parent? No, they can never change. And that would be a splitting symptom, But if the child says, yeah, if you're able to change them, absolutely, then I've got a normal direction to the attachment system. So I'll do a little response to intervention to kind of check that out in 4. Then in session 5, I'll meet again with the allied parent. By this time, I have a good indication of what's happening in the family, and I'll provide feedback and treatment plan recommendations and observe the allied parent. If they're creating the pathology, well, there's 2 symptom features that will emerge when I present the treatment plan, and the finding that the targeted parent is not abusive based on all the reporting and based on the situation, that's normal range parenting. And now normal parents, a normal allied parent, if you tell them there's no child abuse, will be so relieved. But a pathological parent needs the pathology. They are creating it to serve their own needs. So you will see two symptom features. One is they will become obsessively fixated on maintaining the protective parent role and on empowering the child to reject the targeted parent. And so that's a response to intervention I can look at. And that's because the trauma reenactment narrative of their delusional beliefs is in the pattern of abusive parent, victimized child, protective parent. And they need that pattern needs to have corrective pieces to it. They're in their own child abuse history, there was no protective parent available and they were helpless. So in the reenactment narrative, those features are changed. This child now has a protective parent, and that's an important aspect of their working through their own trauma. They must be in that protective parent role, which requires an abused child for them to be in that role. So if you take away and say the child's not being abused, no, they need to be in this role. And so they keep wanting the child to be abused. They want the child to be abused because it's their role. No normal parent wants their child to be abused by this parent. When you get to session 5 here, this parent will want the child to be abused. And the more you try to say, no, they're not, the more they will do that. And then they want to empower the child to reject the targeted parent, because that's a second corrective thing. With themselves as a child, when they were abused as a child, there was no, they were vulnerable, they were weak and helpless. So now with the anxiety, the reactivated anxiety, they empower the child. Now their anxiety drops and they correct the trauma reenactment narrative. So that's what you'll see with a lied parent in session 5. And that's confirming the diagnosis that's earlier. And then session 6 is feedback to the targeted parent. Now here you typically, if the allied parent is creating the pathology and you tell the targeted parent that, they say, yeah, good, okay, and they're agreeable to the treatment plan. If they are the abusive parent, then when I tell them they're an abusive parent, you're going to see a lot of narcissistic display from them. And so that will be a different category of response. So for family court diagnoses, the risk assessment for possible child abuse is that the only cause of severe attachment pathology, a child rejecting a parent, is child abuse by one parent or the other. The attachment system always motivates the child to bond to the parent. So if you got a child rejecting a parent, that's going to be abuse by one parent or the other. So in all cases of court-involved custody conflict involving severe attachment pathology displayed by the child rejecting a parent, a proper risk assessment for child abuse needs to be conducted to the appropriate differential diagnoses for each parent. And so let me emphasize that. All of these cases should be getting a proper risk assessment for possible child abuse to the differential diagnoses for each parent, just based on the child's symptoms. And none of them are getting that. So we are failing routinely in our duty to protect and routinely misdiagnosing the pathology because we're not even assessing, you're not even assessing for the pathology. So we need to get this in. We need to recognize this as child abuse and start responding appropriately to possible child abuse by one parent or the other. That's the only thing that produces a symptom. Now, all the forensic custody evaluators who should be returning a child abuse diagnosis every single time because that's the only thing that causes a symptom and they have duty to protect obligations. They are never returning. That means they are misdiagnosing it routinely and routinely failing in the duty to protect and routinely not providing the court with the necessary information about child abuse that the court needs for its decision making. Forensic psychology, these forensic custody evaluations need to end, and clinical psychology, diagnosis and treatment comes back. there's forensic psychology. These custody evaluators are a experiment, a quasi-judicial role for doctors. There's no quasi-judicial role for doctors. It was an experiment. It's a failed experiment. Doctors need to go back to being doctors, diagnose and treat pathology. Courts decide on custody. What the court needs is information about which parent is abusing the child. So the differential diagnoses in all cases of court-involved custody where the child's rejecting a parent, the differential diagnosis is the targeted parent abusing the child in some way, thereby creating the child's attachment pathology towards that parent, or is the allied parent psychologically abusing the child by creating a shared persecutory delusion and false factitious attachment pathology in the child for secondary gain to the allied parent? So there's your differential diagnosis that needs to be addressed in all of these custody cases. And the court should be receiving clear information from professional psychology about this set of differential diagnoses. The diagnostic questions that need to be answered in all of these cases, these are the questions that the court needs answered, that the mental health professional should assess for and answer for the court and for treatment. Is first, is the targeted parent abusing the child in some way? If yes, specify the type of abuse. We're going to put it on a treatment plan and fix it and fix all the family relationships. And that needs a yes or a no answer from the mental health people, from the doctors. Or is the allied parent psychologically abusing the child by creating a shared persecutory delusion in the child? Yes or no? And is the allied parent psychologically abusing the child by creating a false, factitious attachment pathology in the child for secondary gain to the parent? Yes or no? We got two potential DSM-5 diagnoses here. And then the third or the fourth dangerous pathology here is the spousal abuse, which is the allied parent using the child as a weapon of psychological spousal abuse of the targeted parent? So those are the diagnostic questions that need to be answered in all of these cases. So let me emphasize the spousal abuse of the targeted parent here, because duty to protect obligations are for everybody. Okay, including the parent, including spousal abuse of the parent. And so there's a second abuse pathology of concern in the family courts, and that's the possible spousal psychological abuse of the targeted parent by the allied parent, who has a dark personality, dark triad, vulnerable dark triad, or dark tetrad personality parent, using the child and the child's induced pathology as a spousal abuse weapon. That's a DSM-5 diagnosis, V995.82. It's wrong up there. 0.82, spouse or partner abuse psychological. And all mental health professionals have duty to protect obligations for all forms of abuse: child abuse, spousal abuse, elder abuse. Now, any diagnosis returned into the legal system will be a disputed diagnosis, that because the legal system is an adversarial system that challenges submitted evidence. So it's going to be a disputed diagnosis in the legal system. The appellate system for a disputed diagnosis in healthcare is a second opinion. So the court, we should be getting second opinions on these diagnoses routinely to reduce those false negatives and false positives, and we want to get accurate diagnoses all the time. And the way to do that is get second and even third opinions on it. So what the court should do is designate a psychologist to conduct the primary assessment for the court, and then allow each litigant parent to appoint a second opinion of their choice to participate in that through telehealth. We have telehealth, we have the internet, we have the ability to do second opinions directly in the assessment, or in third opinions. So appoint someone to conduct the assessment. This is what it looks like in a diagram. Each litigant 1 says it's child abuse by the targeted parent. Litigant 2 says it's child abuse by the allied parent. So then we move that into a clinical diagnostic assessment for the relevant differential diagnoses and let each litigant appoint a consultant to that assessment. So now you're going to have potentially a 3-doctor appellate panel to return a decision to the court about what's going on here. And that's going to get the courts excellent mental health information. If you have 3 doctors working on this, and it's not that, wouldn't be that expensive because you have just the primary report and then each one can hire their consultant on their own and they share the primary psychologist fees. And so then that clinical diagnostic assessment yields the diagnosis that goes into the court's decision making and then ultimately into the treatment plan. Diagnosis guides treatment. Are we treating cancer or diabetes? Are we treating child abuse by the targeted parent or child abuse by the allied parent? Those are very, very different treatments. And here's what it looks like as we move it into treatment. And so if we flip that previous diagram on its side, the court orders a diagnostic assessment. Each of the litigants appoints a second opinion consultant to that assessment. But then as it moves into treatment, that treatment provider then also has the availability of 2 consultants on the treatment who can also consult through telehealth on the treatment and who were there at the initial assessment, which is going to improve the quality of treatment. So you will get improved quality of diagnoses being returned to the court, which is why we do second opinions in healthcare, and you will get improved quality of treatment once it moves into that phase, because you have second opinions who were participants in the initial assessment. So a disputed diagnosis also would benefit from clear documentation of what the symptoms are, because diagnosis is a pattern match of the symptoms to the diagnostic criteria. And so if you have the 3 symptoms of schizophrenia, then that's your diagnosis, whether you like it or not. And so documenting symptoms will provide the clarity necessary surrounding disputed diagnoses. So the child's symptoms and the parenting of the targeted parent should be documented by all of the involved mental health professionals. What are the child's symptoms? Let's get clarity on that. And what is the parenting practices of the targeted parent? Let's get clarity on that. Now, I developed 2 instruments that can do this. One is the diagnostic checklist for pathogenic parenting, and that documents the professional judgments regarding the child's symptoms. So every involved mental health professional should complete a diagnostic checklist of pathogenic parenting so we can get clarity on what they're seeing in terms of the child's symptoms. In addition, the parenting practices rating scale documents professional judgments regarding the normal range or abusive range parenting of the targeted parent. And so all the mental health professionals should also complete that so we can get clarity on what they're seeing and any discrepancies in what they're seeing and get that cleared up. So those are the 2 instruments for the child symptoms diagnostic checklist, and for the parenting, the targeted parent, the parenting practices rating scale. So with that provides a summary of the diagnostic assessment of child abuse in the family courts. So we have multiple pathologies here. We have possible delusional thought disorder. We have possible factitious disorder. We have an attachment pathology. We have child abuse by one parent or the other. And that needs a proper risk assessment relative to the family and the child so that we can take the proper steps to protect the child. One of the prominent dangers of a delusional thought disorder, a shared delusion, is that if you believe the shared delusion as if it was true, you become part of the shared delusion. And dark personalities are highly manipulative. That's a symptom feature of the darks, Machiavellian manipulation. And if they manipulate you, The narcissist is very seductive in terms of their presentation, and the borderline is also known for being very seductive. And so if you believe the shared delusion, you become part of the pathology. And when that pathology is child abuse, you become part of the child abuse. You, the mental health professional, you, the court, you, the GAL, you, the minors council. If you misdiagnose this pathology, you become part of the child abuse. That's not true with ADHD. If you misdiagnose ADHD, you're not a child abuser. If you misdiagnose autism, you're not a child abuser. If you misdiagnose this pathology, you become part of the child abuse and part of the spousal abuse, using the child as a weapon. So that's why we need an accurate diagnosis. Let's get second opinions on it. Let's document the symptoms so that we're confident in our diagnosis and that we can take the appropriate action to protect the child from whichever parent the child needs protection from. So with that, that's assessing and diagnosing child abuse in the family courts. And I'll go on to another seminar in the next session.